Hi everyone, and thank you for joining this NHS Providers webinar. Just a reminder, NHS Providers is the membership organisation for all NHS hospital, mental health, community and ambulance services. This session will look at pressures facing NHS trusts this coming winter in the context of the pandemic. We're joined today by Chris Hopson, Chief Executive of NHS Providers. Over to you, Chris.
Thanks everybody who's on the call. I think we've regard these as important opportunities to kind of share where things are up to as from our perspective, but also give you the opportunity to ask questions. So I think it's always good to have a dialogue rather than me go on and on and on. But I thought what I'd just basically do is just start off by just talking a bit about how we view the next 3 or 4 months. I mean, it's impossible to kind of, have a perfect crystal ball of exactly what that might look like. But I thought what might help would be to just give you a sense of, as we've been talking to our hospital, community, mental health and ambulance chief executives and chairs over the last kind of couple of weeks, about how they view what's coming up. So I think, as we all know, what potentially we have is a very interesting combination of a COVID second surge that is clearly now with us in a number of different parts of the country, happening at the same time as winter, which is when the NHS is at its most busy and when capacity is at its most stretched, at a time when in order to ensure that we separate out COVID and non-COVID patients and keep them safe, nearly all hospitals have lost somewhere between 10 and 30% of their capacity. And we're trying to do this and have this kind of potential combination of difficult demand in terms of both winter and a COVID second surge at a point when our staff are really tired. Again, I think one of the things when you talk to chief executives is the thing that probably is most worrying them and potentially is kind of at the top of their list in terms of worries, is that sense that we've been asking our staff to go at full pelt from last winter, then through to doing some pretty extraordinary things in the first phase of COVID. We've then asked them to go again to get through some of the care backlogs that we are in the process of working through. And then we're then asking them to go into winter at a point when, for example, we know there is significant amounts of outstanding leave, when we know, for example, there is probably likely to be higher levels of sickness due to the COVID second surge. So I think a real concern that, at its most, if you use that fairly trite phrase, there is the potential danger of a perfect storm if all of those things kind of come together and occur at the same time. So what I thought I'd do is we quite often issue a what does winter look like document. We're still having a bit of a debate about what might winter look like, but if we were perhaps to kind of write that at the moment, we tend to do in a fairly simplistic way, what are the things that we think are positives and good things about this year compared to the previous year, and what are the things that we're worried about. So if I look at the things that in a sense we think are kind of better this year, compared to the first phase, there's probably 3 or 4 or 5 things we put on that list. I think there's absolutely no doubt that we have a much better understanding of exactly how COVID works compared to the first phase. I mean, you'll remember that one of the really interesting things that happened in the first phase is people, clinicians, really not knowing exactly what they were dealing with and having to rely on some quite often fragments of information coming in from China, coming in from Italy, and coming in from Spain about what the best way of dealing with COVID was. And I think there's a very strong feeling that we have learned an awful lot about the best ways of dealing with patients who've got the more serious end of COVID symptoms. So just to pull out a couple of things there. So for example, you'll remember in the first phase, there seemed to be a pretty clear view that the real issue was, would we have enough ventilators ventilators because we'd have very large numbers of patients who would needed intubation, who needed to use mechanical ventilators in critical care. But relatively quickly, I think, in that first phase, I think there was a recognition that actually probably oxygen therapy and oxygen treatment on wards without actually having the formal putting the tube in through the throat for mechanical ventilation, that for most patients, actually that oxygen therapy was the best way of doing things. You will also have heard quite a lot of publicity around, dexamethasone and also remdesivir, but particularly dexamethasone, which, as you know, is a relatively kind of cheap steroid, very widely available, that seems to have a really pretty significant kind of difference in terms of improving outcomes. So I think when you talk to clinicians and you talk to chief execs, what they say is they just feel they're in a completely different place from where they were in the first phase in terms of understanding what they need to do to treat patients. And this is very good news, effectively, we are seeing significantly improved outcomes. I think one of the figures that we've been quoting quite a lot is that what we're finding is that whereas before, if you were in critical care, the survival rate tended to be around 65%, that's now gone up to around 80%, thanks to that real understanding of what the best treatments are. I think a second thing that we would say, and again, I'm sure you've picked this up, those of you who are close to the world of health, is what happened in the first phase is that systems worked together much more effectively. You'll remember that under the 2012 Health and Social Care Act, that a lot of people have said they were concerned about the way that it atomized the NHS, and effectively, particularly on our side of the house in terms of providers, it basically put trusts in a position of where the thing they worried about most was their own success. And I think what's really emerged very successfully from that first phase is the way in which trusts, GPs, social care have worked together really effectively. I know this is a slight source of kind of political debate and controversy, but the area that we would point to is the degree to which the hospital discharge process worked much, much more effectively in that first phase. And again, I know there's a debate about how effectively that process worked, and did hospitals, seed COVID in care homes. But I think there's a very clear view from not just hospital chief executives, but also from community trusts, mental health trusts, and to be fair, from social care and GPs, that actually that's a very good example of where, by getting the discharge process to work more effectively, systems have worked together. So there's a pretty clear view, I think, that if we can carry that on, there are some significant advantages. I think the other bit that particularly also worked well in the first phase was that sense of hospitals and community mental health and ambulance trusts, but particularly hospitals, working together in groups. So again, I think you've probably heard us say quite a lot that one of the great advantages of a National Health Service is the fact that actually, if you get into trouble and you find that you've got more patients than you've got capacity for, which is again what we were seeing in that first phase in Italy and in Spain, actually to work in a National Health Service where you can call on the neighbours to help is really important. And certainly what our chief executives say to us is they feel they've got much, much better, more well worked through plans to ensure that if they need to call for help and they need to transfer patients either to other NHS hospitals, or if you're talking about elective surgery or potentially urgent surgery, you can also potentially call on the private sector. There's a real sense that those plans were pretty well developed and pretty well worked through in the first phase, and they're there to be activated as needed. And again, I think it's been fairly well publicised over the last few days that that's, for example, what's been going on in Merseyside as the hospitals in Liverpool, particular hospitals, have come under real pressure. So I think, again, there's a feeling that was helpful. What we've also then got, and again, interesting kind of debates around this, is we've then got the potential extra capacity of the Nightingales in place. Again, the debate revolves around, well, you didn't need them, so why did you build them? But that was the whole point. We built them so that the capacity was there if we needed it. Luckily, thanks to the way that the disease spread or didn't spread, actually the virus spread or didn't spread, it turned out that actually we didn't need them, but we still have them there and they are still available for use, so that if we do find that we are coming under real pressure in the service, there is the opportunity as part of those capacity sharing plans across regions to use them. Again, a little tiny administrative or sort of, bureaucratic detail. The other thing that we would point out to you is that if you look at the structure of NHS England and Improvement, the fact that they created regions in a proper way, a regional structure about a year and a half ago, there's a very strong feeling that that again stands the NHS in good stead. And that's one of the reasons as to why we've developed these effective plans which enable capacity to be shared where needed. I think there's a pretty clear view that had those regions not been created in the way they were about a year and a half ago, we wouldn't be in the position that we're in. The final bit I would point to, and again, sorry, a lot of these seem to be matters of controversy and debate, but I mean, certainly our chief executives say to us that although test and trace has had its problems and is still having its problems, we do now know much more clearly about where the disease is spreading and the speed at which we're spreading. And the whole point about the first phase, that we simply didn't know how much coronavirus we were going to see where and how quickly it was going to grow. And that therefore creating those 33,000 beds for coronavirus patients was the only sensible way to ensure you had the capacity available if the virus spread pretty quickly and pretty universally. What we're now able to do, and you can absolutely see this playing out in real time as we speak, is because there is a clearer understanding. It's not perfect. We know that tests are taking too long to come back. We know that particularly as the virus spread rates are rising, NHS test and trace is coming under real pressure. But I can't tell you the difference in terms of the amount of intelligence that we now have about where this virus is spreading and the speed at which it's spreading is making a very significant difference and is helping us kind of plan accordingly. So again, it's one of the reasons as to why we've been able to do the more regional approach to lockdown, for example, that we certainly wouldn't have been able to do in the first phase. So if you add up on the kind of plus column, it seems to us that all of those factors, hopefully, I know there's one more as well, which is, and this one is less certain, but interestingly, it's beginning to kind of enter, the popular narrative, is that actually, if you look at the flu rates, and again, that one of the things that tends to knock the NHS over in winter is the amount of winter flu. What's deeply fascinating is if you look at the flu rates in the Southern Hemisphere, where clearly they're in their winter, and we've always used the flu rates in the Southern Hemisphere as relatively good predictors of what's going to happen in the Northern Hemisphere, our part of the world, when we get round to November, December, January, February. What's deeply fascinating is that actually the flu rates appear to have dropped dramatically, very consistently across the Southern Hemisphere. And what the epidemiologists are basically saying is that it's probably the combination of lack of social contact, but also wearing of masks, that obsessive hand hygiene that people are now, doing as a result of COVID, is probably making a very significant difference in kind of cutting flu transmission rates. So it's very, very early days, and there have been years where actually there is a significant difference between Southern and Northern Hemisphere flu rates, but there is emerging optimism that one of the principal reasons as to why the NHS gets overwhelmed in its worst winters of a very big winter flu outbreak, we're hoping that that will be less this year. And again, I think, as you probably know, there's a lot of work going on to ensure that flu vaccination programs are as effective as possible. So I had my flu jab from my local GP last weekend, and we know that there's a lot of work going on to ensure that that happens. So if you add all of that up, those are the plus points. I won't dwell too much on the negative side, on the sides that things are going to make more difficult, because in fact I sort of set them out really already, but just very quickly to run through them. We do have that problem of the fact that because we need to separate out COVID and non-COVID patients, we absolutely do need to ensure that for effective infection control, we do have to do things like, separate out wards, separate out operating theatres. It's very, very different in each hospital, depending on what its layout is. So if, for example, you are able to build, as some hospitals have done, some diagnostic capacity out in the car park and just use that for either your COVID or your non-COVID patients, then that dramatically increases your diagnostic throughput. If it's easier to effectively, you happen to have your theatres in two different blocks, your operating theatres, again, that's much easier. So what we're finding, what most chief executives are saying to us, is that in hospitals is there's somewhere between 10 to 30% capacity down. And clearly that is a worry at the point when we know in winter we are kind of, at our most stretched capacity wise. Again, you've probably seen us say publicly pretty clearly that we believe that one of the problems for the NHS over the last 3 or 4 winters has been we've simply not had enough capacity. So not only do we not have enough capacity for winter ordinarily, but we've now lost 10 to 30% of that hospital capacity on the basis of having to separate out and COVID and non-COVID patients and effective infection control. So that does mean that if we do have numbers of COVID patients kind of coming in, that will have some impact on how much other care we're able to provide. Though the thing I really want to reassure you on is that we are absolutely aware that we have to do the very best we can to get the right balance between COVID and non-COVID patients. And whereas the first phase was very much around, let's create those 33,000 beds, we're absolutely clear that the key task now is to try and keep elective surgery going as much as possible and try and absorb any extra COVID demand that kind of comes in on top. I've talked about the staff issues. I think I went round those really pretty consistently. The other thing that is just beginning to concern people is, having talked about how positive the discharge process was in the first phase, we're definitely getting the sense over the last couple of weeks of people basically saying that they're beginning to see the discharge process slow down. And again, those of you who talk to your local hospitals will know that one of the problems we've had in previous winters has been that we've had large numbers of people who've been medically fit to discharge, but because there is insufficient capacity in social care, then effectively that has blocked the flow through the hospital. So, as I said, having done that job, debate to be had about what the consequences were of actually discharging large numbers of patients at speed in the first phase, there is a nervousness that actually hospitals are beginning to kind of, I'm trying to find my right words here, but we're beginning to find larger numbers of medically fit to discharge patients who can't be discharged in the way that hospitals would ideally like. So one of the things that's certainly worrying chief execs at the moment is, if you look at the occupancy rates, and we haven't really hit winter yet, you're seeing occupancy rates of 92, 93, 94%, when you would be expecting and hoping to see them being starting with an 8. 85, 86, 87. So a real kind of sense that, that may cause pressure. Final couple of points to make. As ever, as you would expect, NHS staff and leaders are going to do everything they can to provide the best possible care. But if it does get difficult, if there is a if there's a prolonged cold snap, and we do get large numbers of people coming into hospital, as we often do in those periods, and needing ambulance services, etc., then the NHS is going to come under significant pressure. And my final point is just really to say that just to reinforce the point, that's probably what's most on chief execs' minds at the moment, is how do we ensure that our hard-pressed staff do have a reasonable, as reasonable a workload as possible this winter, which is why they've been pushing very hard to ensure that if, for example, there is a debate about whether there should be a local lockdown or not, or whether it should be tougher or weaker, their very clear view is they want to see the NHS being given the best possible chance to treat as many patients as possible, and to ensure that the staff are given a reasonable workload. And one of the ways we can control that workload is by cutting the virus transmission rate and by ensuring we see less COVID-19 patients. So, summary, it could get very, very difficult, but the NHS will do absolutely everything it can do to meet the patient demand that it sees. Kerry, I hope that was helpful.
That was. Thank you, Chris. So we've got our first question from Rosie Winston MP.
Hello.
Hi.
Hi. Thank you so much for that presentation, and thank you to all your members and staff for everything that you're doing in what is an incredibly difficult time. Really very grateful for it. Can I just press you on a couple of things? First of all, the Nightingale hospital issue.
Yeah.
As I understand it, last time the reason why it was not necessary to bring them forward was because it was like cancel everything else that's going on at the moment, cancel elective surgery, etc. So in a sense, all the COVID patients were able to be absorbed within the local trusts. But this time, the message is more, no, keep as much going as you can in terms of elective surgery. But clearly, there is going to come a point where that is not going to work. And I just wondered what you felt the point was at which you say, well, we really can't keep elective surgery going because we just can't absorb everything. And what are the issues with there around asking for the Nightingale hospitals to be opened, and what ought we to be doing to sort of look out for that point, and what could we be doing to support any calls there are? A sort of constituency issue that arose, but must be happening elsewhere, on track and trace.
Yep.
One of my constituents was told, after having been a visitor, you need to go and self-isolate. That was by one of the staff on the ward, but because it is somebody on the ward saying, go and self-isolate, that person cannot get on the track and trace system and get any of the isolation grants. And I just wondered whether this was something that it might be worth looking at as a kind of protocol somehow, so that people like that, because this person was self-employed and was faced with, do I obey the advice, or how do I can't get onto the system because it hasn't come through that particular system. So I just wondered if there were any kind of protocols that could be drawn up to make sure that people like that could get some help.
Okay, thanks, Rosie. Two very good questions. So on the Nightingales, they're very much part of those regional plans, and it will be for the regional the chief executives of the hospitals in that region and the regional directors, the NHS England and Improvement Regional Director and their team, to basically work out what is the best point at which the Nightingale should come on stream, and crucially, what patient demand it should be looking to, to take in terms of what kind of patient should it be looking to take. One of the things that I think it's important to remember is that two things about Nightingales. One is they're clearly not custom built hospitals. So effectively, if you have the ability to treat the patients that you need to treat in an existing custom built hospital, you would want to do that. And secondly, in terms of the staffing model, I think, again, Rosie, as you probably know, we're about 80,000 staff down in the NHS in terms of staff vacancies. So if you want to staff a Nightingale, the chances are you'll probably have to take people off the existing hospital, away from their existing hospital, not completely, but certainly many of the key positions you'll have to ask people to redeploy from the existing hospital. So you do face a slight problem of robbing Peter to kind of pay Paul in order to kind of get the Nightingales up and running. So in terms of at what point and for what purposes, the other point to make is that it will vary according to different places. So we know they have been configured in different ways. We know that some of them are actually being used at the moment. So for example, the one in Exeter has very deliberately been configured to effectively do some basic diagnostic casework so that effectively, as required, it can be used to process people who need basic tests, because they happen to, in that one, have got some, I think it's basic MRI and CT scanning equipment in there. So in terms of how do we ensure that the NHS gets through as much of its patient casework as possible? That is something, as I said, that is sort of discussed almost on a daily basis. And certainly when you get into, if you get into the point where you need to trigger the Nightingales, that will be a matter of discussion between the individual hospitals. And what they might say is, well, look, okay, we now have to, for example, convert 2 or 3 wards from elective surgery to COVID. So could some people in the rest of the system take up the slack in terms of that elective surgery? Yes, somebody might say, but actually we probably have now reached the point where we could transfer these cases to the Nightingale, so let's get the Nightingale up and running. So as I said, it's difficult. I can't be definitive for you about exactly A, when, or B, what the circumstances would be, because it will be a decision that will be made by the chief execs and the regional team. And certainly I would expect and hope that your chief executive of your hospital would be giving you appropriate information at the point at which that might happen. You asked a really good and helpful question though, Rosie, about what can you do to help? I mean, just from where I sit, one of the things that would be helpful would be effectively to hear members of parliament. There are some people who are running around saying, NHS has been profligate and wasteful. Why have they had all of these Nightingales? Why are they not being used? And there are various people who are around who are trying to have a bit of a poke at the NHS for various things that they have done or haven't done. And I certainly think MPs from where we sit have got quite a valuable and important role because of the credibility and authority you carry in your constituency and with your local media to basically act as not as an uncritical or an unchallenging cheerleader, but just to help explain about what the NHS is kind of trying to do and why, for example, it did make sense to build that extra capacity. And there are good reasons as to why it wasn't used in the first phase. And actually, that's a good thing, not a bad thing, because I said there are some people who are pretending that, this was a very silly thing to do. It's a waste of money. So I recognise that for you to do that job, you need to have the information to do it. And certainly, again, I would hope your local hospital would do that. But if you again need help from us, we're hopefully very in a good position to help you do that. I'll have to pick up the test and trace one and come back to you. I mean, we've got very good contacts, a very good relationship with the senior leadership team in test and trace. And I will ask them that question about because it seems to me a very obvious and sensible one, about if somebody has gone on to a ward for good reasons. My expectation and my hope would be that I assume, again, tell me if I'm getting this wrong, that actually the hospital might help that person out with personal protection equipment, with PPE, and therefore, because the way that this works at the moment for NHS staff is if you're appropriately protected when you're in contact with COVID staff, with COVID patients, actually you obviously don't need to self-isolate because you've been wearing PPE. So
could I come back just to say, yeah, my recollection is that the visit had taken place before the patient was diagnosed with was tested for COVID. Yeah. So it's slightly retrospective. That was the issue. And also, by the way, my local hospital is very good at keeping in touch and so on. But I'm just very aware that at the moment, there are big issues. So you don't want to be bothering them the whole time. No, this was, as I say, the patient had been diagnosed, then the relative is told, oh, right, you've got to now self-isolate, but no way of getting onto the NHS system, so no way of getting...
So Kerry, we should pick that up with Dido, and basically I'll pick that up, Rosie, and I'll send an email and come back to you as quickly as I can. And what you're absolutely right to identify is that one of the tricky bits we've got here, and again, my kind of sense is I would like to have seen more public debate around this, is that one of the problems we have here, which makes life particularly difficult, is the presence of those asymptomatic patients, where effectively you can discover after the event that actually somebody's been spreading this virus, or has been as effectively is potential for infection and may have been spreading, and you only discover it when you do a test 2, 3, 4 days later. And it particularly, and again, you'll probably have seen this, Rosie, it gives us particular problems in terms of asymptomatic staff in health and care settings, where actually people can have the virus and be infectious for a period of time, and could come into contact with patients who, and quite often if you're in a health and care setting, you're going to be coming into contact with people who are vulnerable and who, to be frank, can then experience the more severe consequences. And therefore, one of the issues that we've been grappling with, and again, you've probably been following this debate, is the point at which and this point we've made quite a lot recently, is that we do need to try and get as quickly as we can to a point where we are testing all health and care staff on a regular basis. We are now meant to be testing care staff once a week, but in the NHS we're still waiting to see when we might move to testing all NHS staff, precisely because of that asymptomatic issue.
Although I also have another constituent who has tested twice positively for COVID over a 19-week period, was sent home to self-isolation the first time, but when tested again, still has it, but has had to go home again. So even though she probably isn't infectious because of having had it that long, which is another staffing issue, quite interesting.
Yeah, and I think Rosie, there's some stuff going on here, isn't there? One of the issues is that we do know that the results do throw up false positives, and we need to be, and they also throw up false negatives, and each of them, in a sense, has its own set of problems with it. The other one that you probably would have seen from today's newspapers, which is a source of significant concern, is that there is also a suggestion that effectively the presence of antibodies diminishes over time, and that therefore actually what you can be test positive legitimately and then come back a period of time later and actually find that you've lost your immunity because the antibodies effectively have deteriorated over time. So actually you are capable of catching it a second time. And then there was also those outbreak of cases about 3 or 4 or 5 weeks ago, where also there was a suggestion that actually there are different strains, and that potentially you can catch it a second time over from a different strain. So again, part of the problem here is we just don't know precisely what we are dealing with, and that we're therefore kind of on a bit of a learning curve, which, given the potential consequences of this virus, is not a particularly comfortable or happy place to be. Is that helpful, Rosie? Was that
very helpful? Thank you. Very helpful.
Just before we go on to more audience questions, we've got a question that somebody sent in that wasn't able to attend, and that mentioned the Sunday Times story. how the NHS treated patients in the first phase. They said that it was quite worrying to hear that potentially patients were being excluded from care. I wondered, Chris, if you could give the perspective from our members on what that actually looked like for them.
Well, can I start privately, please, with my mum, which is that I was really concerned when my mum said to me on Sunday evening she'd read the Sunday Times story and was really, really concerned about it. And was this true? And it is particularly difficult because we are at a point when, understandably, people are very concerned about stories like that. Our view is that the story was overwritten. It's not correct. And for us, what they're doing is mixing up three different things. And just give me 2 or 3 minutes to explain. The first bit is we know that decisions that are taken to admit patients into hospital or to put them from move them from a ward into critical care, they are taken by individual clinicians on the basis of the circumstances they see in front of them. And we certainly have got every chief executive that we've spoken to has been very clear that we haven't changed the triage. I mean, there's, decisions about who to admit to hospital and who to put into critical care are made every day of the week, before COVID, in the middle of COVID, and they'll take place after COVID. And people are very clear that the general triage, the general approach to triage has not changed, and that effectively people are admitted to wherever they need to be on the basis of the individual diagnosis that is made by the individual clinician. So that is a process that kind of goes on every day of the week. And we do know that there are people who have had COVID really quite seriously, who have been treated on general wards because that's where the oxygen therapy is best delivered. And there have been lots of patients who've recovered as a result of that oxygen therapy, who haven't needed to go on into critical care and mechanical ventilation. Rather more distressingly, there have been some patients who, to be frank, are sufficiently ill and effectively have, for example, got multiple organ failure, that the reality is that what they need is the only appropriate clinical treatment is palliative care. And you don't deliver palliative care in a critical care unit. So one of the things that the Sunday Times was suggesting was that because there were spare critical care beds, and actually there were people who were dying on wards, that was a problem. Our view is really very clear, which is the existence of that situation in certain places simply does not reveal there is a problem per se. What it effectively says is that you were in a position where individual patients were being appropriately allocated to the place where they were best treated. I suspect there probably were a small number of places, and this is the second bit, where effectively there probably was pressure on critical care beds, as there often is, and therefore people did have, as part of that triaging, to basically make some decisions about who had access to those critical care beds. But again, those decisions are not based on age alone. And those two situations are completely different, it seems to us, from what the Sunday Times was arguing, which effectively was that systematically and consistently, on the basis of a draft triage tool that had been developed, the NHS was effectively deliberately excluding large numbers of elderly patients from either critical care or from hospital by keeping them, quotes, on wards to die, or by deliberately saying they weren't going to admit patients from care homes. Now, I don't think there is any evidence from what we have seen to support that contention. As I said, I've been careful in my use of words because clearly there were instances of where people were, I'm afraid, dying from COVID on wards where there were spare critical care beds, but that was for a very good reason, which is those people needed palliative care, and you don't deliver palliative care in critical care units. So in our view, the way the Sunday Times story was written, and in particular the sort of suggestion that the NHS has been deliberately and consistently effectively denying care to people on the basis of their age is simply not true. And if you have the chance and are interested in this, I did quite a long tweet thread on Sunday night where I also pointed out 2 or 3 important facts. One is, at no point did the NHS run out of critical care beds. So actually, we simply wouldn't have needed to have done that kind of consistent triage right the way across the piece to basically be denying people who needed care. And secondly, if you actually look at the critical care data about who actually went into critical care beds over the last 9 months, the age profile of people in critical care has basically been pretty much the same as it was before COVID. And if it was true that we were deliberately excluding people of a certain age, above a certain age, from critical care beds, it would have shown up in the data, and it absolutely hasn't. So I'm afraid, again, I want to choose my words quite carefully. I thought it was a particularly unfortunate and unhelpful story that you could see why, based on some individual case studies, people might have been concerned about it, but to have drawn the inference that that's what was happening consistently across the country from those case studies really wasn't helpful.
Thank you, Chris. So I've got one more question, which is about a recent survey of your NHS members that you carried out, which raised concerns about staff burnout. And I know you touched on this slightly earlier, but do you think enough has been done to kind of support staff to recover from that initial phase before they go into a challenging winter?
Well, as I said, it's absolutely top of chief execs' minds. I mean, I think they really kind of recognise there are some really big issues here. I mean, at its most extreme, I heard, we were talking about this with a group of chief execs the other day, and somebody said something to me which I thought really resonated, which is that when people, the battlefield experience is that when people go through a really traumatic event, what quite often happens is that they sort of suppress what's happened to them. But when they then effectively then come back and experience, or potentially are in a position to experience the same thing over again, that's the point at which, the trauma, recurs in their mind, and you get that sense of, for example, its most extreme PTSD. And again, it's just interesting about how, chief execs were saying that they were doing everything they can to try and identify the risks here, trying to ensure that they're really stepping up very significantly their staff welfare and their staff occupational health offers to make sure they look after people. But they are worried. I mean, a very common story that we hear is, they're really worried about the fact that there is a lot of leave outstanding, and that effectively people have been, because they're very committed, working incredibly hard on the front line to basically, provide the quality of care that's needed. So they are doing their best, but it's not easy in an environment where you've got the kind of demands that we've been talking about, where you're at 80,000 vacancies down, and where and you're also, by the way, particularly in areas of high COVID spread, you're seeing higher levels of staff sickness. So effectively, you've got a reduced workforce. So a real sense, I think, of, it's very, very difficult. But if you want the NHS to kind of carry on providing the services we would all want to, we are having to ask a lot from our staff. It does. One of the things I'm really keen we should do is learn some of these lessons. And, we've all been saying in both health and social care that we've got unsustainable workforce models, that effectively we're just having to ask our staff to go the extra mile and a half, day in, day out, week in, week out, month in, month out. And I think this has really, really brought this home. So one of the things we are very determined to do is to effectively shine a really bright light on the fact that we've got to get to a more sustainable workforce model, where effectively we get back to asking our staff, yes, of course, to go the extra mile once every so often, but you can't keep asking people to go an extra mile and a half every single shift, every single day.
Thanks, Chris. We've now got a question from Liz Twist MP.
From the Northeast. So I wanted to ask really about the parallel running of COVID-19 cases on the increase and other surgical and non-surgical treatments, which I know are getting up, but are going much slower than usual because of the need to have PPE and protective mechanisms between patients. So that's happening. At the same time, I'm hearing that, the government having said early on, the money's there for whatever it takes, that actually it's all being badged as one thing and there's not the money for that dual running. While in COVID-19 at the height, we actually had everyone focused on one thing. Sorry, that's a bit convoluted, but it's they running two systems at the same time, really.
No, it's a very good question, Liz, and it's obviously something that's really important. So just to make the point that what happened in the first phase was that because we had to concentrate on creating those 33,000 beds, then effectively there was a focus on ensuring that that occurred. There is a lot of misinformation. It never was a COVID-only service. We did ensure that everybody who absolutely needed treatment did get that treatment in terms of the most urgent cases. But yes, you're right, and we would never want to minimize this. We did have to delay a number of particularly, more regular elective surgery cases, and we are now having to kind of pick up the backlog that got created. You're right to identify, and to be frank, one of the problems that we faced, if we're really honest about it, is that for reasons, again, we somewhat understand but are frustrated by and are doing our best to overcome, is that understandably patients didn't want to come to hospital. So part of the problem was you can't treat people if they're kind of not presenting at hospital. So we've again been trying to do everything we can to say to people, it's now safe to come to hospital, please kind of come. So what we're now doing is we are going as fast as we possibly can to recover services. The way we're measuring that is what percentage of operations, for example, are we doing in September and October compared to September and October 2019. And we were set the target of trying to deliver 80% of elective operations, 80% of the number we were doing a year ago in October. And I'm pretty clear that we should have hit that target. So in a sense, we think, certainly our chief execs say to us, that they are going faster than they expected to do. Because when those targets first came out, they said, oh, this looks very, very difficult. But thanks to lots of really good work on the front line, that is kind of happening. However, the problem is that in those areas where you get COVID kind of coming back again, then what happens is that by definition affects your ability to carry on with that rate of improvement. So I was talking to a hospital in the Northwest last week who literally, as I was sort of slightly saying earlier, had to convert two non-elective surgery wards into COVID wards. You asked about the money in particular. So effectively, there is sufficient money, we think, in the system. I use the words we think because trusts were told what their allocations were for the rest of the year about 2 or 3 weeks ago. But they're taking rather, because the allocations have been made on a very complex basis, they are having to spend quite a bit of time working through exactly what they mean. What they've been told is that if, for example, you do have particular financial problems, don't stop or, slow down, they will be sorted. So people have got the very clear message that they shouldn't use the lack of finance as a reason for slowing down what needs to be done. But as you might imagine, Liz, the question everybody is asking is, clearly that's not a sustainable approach longer term because people need to work within a budget. So there will at some point need to be a point where we actually go back to what you might describe as conventional financial discipline, and effectively people get given a budget and need to work within that budget. But at the moment, and there are some very boring wrinkles around this, which I won't go into, but at the moment, our view, I think, is that there isn't a massive problem here. And certainly the sense our trusts have been told, don't slow down or not do things because of lack of money.
That doesn't quite tally with what I'm hearing. And I attempted to ask, I asked a question of Matt Hancock on this and got onto the money's there, of course it's there. That's not exactly what I'm hearing locally.
No, and listen, I wouldn't subscribe to, of course the money is there, get on with it. It's not quite as simple as that. So I suspect I'm probably sort of in a sense halfway between. And the reason being, as I said, that when those allocations were sent out to trusts 3 or 4 weeks ago, and I was talking to quite a few trusts actually in your part of the world, there was a real concern that there was a financial gap. They were told, look, if you work through these in detail, what you'll find is the gap is not as big as you think. And actually, to be fair, when people have worked through the detail, the gap has shrunk, but there is still a gap left. We've gone back on their behalf, as have they, to say, look, there's still a gap here. And what they're being told is, look, okay, there probably are good reasons for a gap at the moment. Don't worry, it will get covered, and keep going, and we'll make sure we'll see you right by the end of the year. To which our chief execs understandably say, well, yeah, fine, but you're asking us to run at financial risk here. So that's not a sensible way of doing things. So again, part of the problem, Liz, I think, without trying to be too dull and detailed about this, is what we're trying to balance here is, you know, give people the money they need to do the work, but on the other hand, don't give them a completely free blank check, because that is not, you know, value for money for taxpayers. So because we're working on a sort of temporary financial system, trying to get the balance between those two things right isn't always easy.
Finally, can I just say that thank you to the NHS staff, and I am concerned, I'm not asking for an answer on this, I'm concerned about the levels of exhaustion on the part of staff who've been working flat out for a long time.
Well, that's what I mean by an unsustainable workforce model, Liz. I mean, I don't think, I genuinely think it's not appropriate to ask hardworking frontline public servants, be they, to be frank, whatever public service they're delivering, to basically ask them to, you know, bankrupt themselves personally in terms of their effort by giving a mile and a half day in, day out. We all know that, you know, in the winter rush, it probably we will ask people to kind of, you know, do a bit extra. But the only way the NHS is running at the moment, and has been running for, I would argue, at least 2 or 3 years, is by effectively trading on our staff's goodwill by asking them to do that extra mile and a half every shift, every day. And it's just not feasible. And what will happen is that effectively the service will fall over if we don't get to a more sustainable workforce model. So I completely agree with you.
Great, thank you both. So I think we've probably just got time for one more question, Chris. And we've had this one in from somebody who had to drop off, and it was about mental health demand. And obviously, people are talking about an increase in concern about people's mental health given the extended lockdown and then the kind of uncertainty that people are facing. Are you hearing from members about that increased demand? Are they worried about that?
No, absolutely. And I'm very glad you raised it, because I've probably been focusing far too much on kind of hospitals over the last, over the last hour. There's absolutely a huge level of concern. And you may have seen my colleague, my deputy, Saffron Caudry, did a very good interview with The Observer at the weekend, where effectively there is a real concern here, which is we know that demand for mental health services is now beginning to increase, and to be frank, increase quite significantly. What we're particularly hearing is that it tends to be patients of higher acuity, in other words, people who do have real severe problems. And to be frank, quite a lot of it is people who, for example, who probably had lower or mid-level problems, but have been unable to access the kind of form of therapy that particularly helped them. So, for example, group face-to-face therapy, they've not been able to access during lockdown. There are obviously other reasons as to why during lockdown people may have developed mental health issues. And the thing that really makes us nervous is that we know this extra demand is coming, and we've been arguing really strongly that we should build the extra capacity to meet that demand now. But I'm afraid we've been unable to persuade our colleagues in government that that is what should happen, and that what they've been saying to us is, well, you know, don't worry, we'll deal with this in the spending review. It's going to come later. Don't worry about it. You know, you'll get an allocation for the beginning from April 2021. But as ever, if you don't build the capacity in advance of it being needed, you get the awkward gap in the middle. So our worry is that this demand is now starting to arrive, and it's arriving in significant numbers, but we're not in a position to deal with it in the way that we would like to. So that is going to be a bit of a debate. And if I can persuade colleagues in Parliament that at the point when we have the spending review, which is now, as you know, probably going to be it is going to be a 1-year review, though the Chancellor has said that he does want to look at what he can do on a multi-year basis for the NHS. One of the things I would urge you to look out for is the Chancellor, are the government making a specific commitment that they will fund the extra capacity needed to deal with that extra mental health demand? Because if we don't, we are going to be letting an awful lot of people who need treatment down.
Thank you so much, Chris, and thank you everyone for joining us and for your questions. I hope you found this a useful discussion. If there are any other topics that you'd like us to cover in a future webinar, do let us know, and we'll share the recording of today's session with you. Thank you again for joining us, and hope to see you again soon.
Thanks, everybody. Thanks, Kerry.